Well, welcome to this topic review in physiology on the basics of the coagulation cascade and specifically the formation of a clot or thrombus. In the next few minutes, we're going to focus on the core concepts every healthcare professional needs to know and connect them, more importantly, to why they matter clinically. Because when you understand the underlying physiology, the understanding of the pathophysiology makes more sense, which then improves the clarity in how we manage a patient care situation and why we implement the treatments the way we do. Hey guys, and welcome. I'm Dr. Busti. Thanks for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the decisions that we make every day in clinical practice. By the end of this review, you should be able to describe the key differences between a venous and arterial thrombus. You should be able to predict what happens when those processes of a thrombus formation get unbalanced or exposed to pathology and that makes things go wrong. And then lastly, explain how the coagulation cascade in the wrong clinical scenario can go bad or south and the type of interventions that are properly required to regulate it to avoid those bad patient outcomes. So let's begin with one concept that makes everything relevant. The two main types of clots that are formed in the body that we need to think about, okay? Now, as we dive into those two clots, you're going to hear me use the words red thrombus, white thrombus. Why do we say that? Well, it comes down to images like this and what is making up this clot right here. Now in this example you see there's a lot of red blood cells there. There's some platelets present there, right? So these are platelets that are aggregating. These are red blood cells. And then these white squiggly lines represent fibrin. So we have components of the platelets, we have components of the coagulation cascade, we have the red blood cells, and all of them are necessary to forming a clot. Now, when you see this diagram, you see that the blood vessel wall here is damaged for some reason. It could be for trauma, injuries, like a cut. It could also be from atherosclerotic plaque in that vessel that endothelial lining has ruptured and exposing the underlying inflammatory stuff that's underneath. And when it does that, it exposes things like collagen, von Willebrand's factor, which is floating around in the blood, deposits there, and that interacts with glycoprotein 1 receptors on the platelets, turns them on. Collagen interacts with the platelet through glycoprotein receptors, turns the platelet on. There's other things that are happening all in this milieu that allows the clot to develop and initiate. And then as it does that, the fibrin and other things and other components from the coagulation cascade come in and it solidifies it. Now the ratio or distribution of platelets, red blood cells, and fibrin is influenced by, is it arterial or a venous thrombus? That matters, guys. For those of you learning this maybe at the earliest stages, or if you're using this as a refresher or you're just making sure you understand it, all becomes essential to understanding why certain diseases are what they are, where there's something missing, like with hemophilia, right? Von Willebrand factor disease, right? That's affecting this part here where the collagen is exposed and the delivery of clotting factors throughout the body, or to also the treatments that we use that are interrupting this when this system is going in the wrong direction in the wrong scenario for the patient, okay? So what I've tried to provide you in this table, and these tables are available at thisiswhy.health for you, free for download. We do put the link inside the video description there for you that takes you to thisiswhy.health where you can access these for studying, share them with your friends, and obviously if you're a faculty or preceptor, you are welcome to use them because that's why I developed them. But this is looking at the two main types of thrombus. And for those of you joining us on our podcast channels, I'll try my best to walk you through this. But it's a table that has two main columns. One column for arterial thrombus, and then the right side is the venous thrombus, okay? Now, The rows represent various characteristics. So what is the initiating factor for an arterial thrombus? Well, that's usually, yes, both of them are vascular injury. But on the arterial side, when we commonly think about the diseases that we're treating and most commonly think about the drugs that we're using, it's predominantly from a plaque rupture, whereas the venous thrombus is usually from altered or stagnant blood flow. So it's just pooling, it's just sitting there. That allows the clotting factors to come together, rub shoulders with each other, start to get turned on, right? So when we think about DVTs, PEs, those are deep vein, that's a venous thrombus, that's formed in that area because maybe someone was post-surgical and they can't move. Or maybe it's pulled the blood in the atrium of the heart in someone with atrial fibrillation. The heart is not having that coordinated beating, and so it's just fibrillating, and so it doesn't get that good atrial kick to move the blood through the valves and into the ventricle. It just sits there. And as blood sits anywhere, it's going to start to coagulate. That's normal. That's what it's supposed to do. But maybe we don't want it to do that in someone with AFib because we can't get the atrial fibrillation to stop. Well, we don't want them to eventually throw that clot and mobilize it, where then it goes down into the ventricle and out into the artery, could go to the brain, cardioembolic stroke. So again, guys, as I teach the normal, I try to introduce the abnormal, where it goes. Why are you learning this? Why does this matter? You're laying a foundation that if you build on it appropriately, makes learning easier and more likely to retain it, not memorize facts. I know a lot of people that memorize things that are clinically incompetent. Just because you can memorize something doesn't mean you understand how to apply it. That's the difference here, okay? Now when you go to row 2, it's the composition. So what is the arterial thrombus, also referred commonly as the white thrombus, right? You'll see that kind of thrown around sometimes in the literature or things that people talk about. But it's because it's primarily made up of platelets. Now it doesn't say it's only, it's primarily made up of platelets. There's still red blood cells there. There's still fibrin there. There's still red blood cells, and there's platelets and fibrin. All those three components are still there. It's just the ratio. So guess what? If a white thrombus, which is primarily arterial, and then most commonly from plaque rupture, what do you think is the drug class that we're going to use most? Yeah, the antiplatelet drugs. Things like aspirin, things like P2Y12 inhibitors or ADP receptor antagonists, or things like glycoprotein 2B3 receptor blockers. Those are the reasons that we target them in those indications where the thrombus is predominantly arterial. What about venous? Well, it's primarily made up of fibrin with the red blood cells. That's the coagulation cascade. That's what we're covering today, right now here in this topic. We're going to be focusing on that, but I'm not going to ignore platelets. Now, we're not going to cover platelet physiology and the platelet, and if you need a review on platelet activation and aggregation, please see my lecture on that. But we'll bridge them a little bit together because you shouldn't learn them in isolation. Now, the last row that you see there is the result. Well, you can get total or partial occlusion of that vessel. And some of those clots that form in the thrombi that form in those areas can dislodge and travel further down or go away from the place of origin. That's when it embolizes. Right? So in a DVT, deep vein thrombosis, we're most commonly thinking about the lower extremity, somebody with abdominal pelvic surgery or trauma or injuries, and they aren't moving, they aren't getting around, that blood's pooling, it forms a venous thrombus that breaks off and now moves into the inferior vena cava towards the right side of the heart. And then it goes through the right atrium, down the right ventricle, and then out the pulmonary artery into pulmonary artery circulation and causes a pulmonary embolism because the vessel is getting smaller to the extent that the clot, depending on the size of it, will eventually clog up somewhere. And that's why patients will develop sudden onset of chest pain, shortness of breath, dyspnea on exertion, lightheaded dizziness, depending on the size of that. But that's a venous thrombus. So we're going to use drugs that target the coagulation cascade primarily. That doesn't mean an antiplatelet drug won't work. It's just what is the main target. Okay? And we call those red thrombi. But again, you can get total vessel or partial occlusion. What was this red and white and fibrin? Well, remember, fibrin monomers are kind of like the cement. It's like the glue, the duct tape that's holding all this together. So what is the primary component distributed in there amongst it? Well, you got those platelets and you got the red blood cells. So a red thrombus tends to have more fibrin and red blood cells, so it has that more characteristic color. And then, of course, platelets on the other side, right? Arterial, typically from arterial plaque rupture. That's going to be why we target that. Now, so there'll be many times we use both sets of drugs classes, antiplatelets, anticoagulants together, depending on what's going on. Okay, so it's important to have that framework as we talk about this. Okay, now the next thing that we need to consider, now that you have some of the basics of a thrombus formation, terminology, composition, is that we need to zoom in a little bit closer and see what this coagulation cascade starts to look like. Okay, so again, I provided you with a image that breaks down the coagulation cascade on the left side, and then on the right side is looking at platelets. Okay, so platelets have to be activated, and there's a number of things that activate a platelet. Turn them on, upregulate glycoprotein 2B3 receptors. But one of the things that turns on a platelet is also from the coagulation cascade, and that's thrombin. Now you're going to see here in this topic review that thrombin does a lot. In fact, when you look at most of the anticoagulant drug therapies on the market and that we use, they target thrombin for that reason, because thrombin is important. It's kind of the king, right? But you see it forms fibrin monomers that help to form that clot or thrombus. So the composition of that has to do with which side of this diagram is predominantly playing the role. But you need to realize that both are involved. Both are involved, okay? And that's huge. Now, you see these clotting factors. There's all these numbers, Roman numerals, and things like that. What are those? Well, those are clotting factors. They need to be made, and many of them have a little A next to them. Well, what is that A? That is being an active form. So let's talk about that. So this particular image shows the chemical reaction of vitamin K specifically in the context of vitamin K dependent clotting factors. That's usually 2, 7, 9, and 10. Protein C and S. Okay, those are the vitamin K dependent clotting factors, many of which are obviously will show up, and we're going to come back to them in a second. But you see over here on the left side is that they get made in the liver, but they're in a non-functional state. They have to get activated. Well, part of the way they get activated is through this enzyme, gamma-glutamyl carboxylase. Now, enzymes facilitate a chemical reaction, and carboxylase is going to carboxylate that clotting factor, and it now makes it functionally active. Okay? So it can work, right? Well, what does that look like? I don't mean to get into some biochemistry and ridiculous medicinal chemistry. That's not my goal here, guys. Don't ignore this part because it actually just makes sense. Don't be afraid of images, okay, and chemical structures, even though chemistry was not always fun. Maybe I just caused some PTSD. But when you look at the main structures, when we carboxylase something with gamma-glu carboxylase, we're adding a carboxyl group. Well, what's a carboxyl group? Just this. We're just adding it on there, okay? Now, you do need vitamin K in the reduced form. That serves as a cofactor to facilitate that reaction. That's important. That's really important for a drug class called vitamin K antagonist known as warfarin. This is where warfarin is impacting this reaction right here. It's preventing the functional activation of these clotting factors, specifically the vitamin K dependent ones, 2, 7, 9, and 10, protein C and S. Now, why do those charges matter? Because you're going to see that calcium is eliminated. It's partially eliminated from the platelet. When platelets get turned on, they release all kinds of chemicals in the milieu environment around them, right? They're like, let's go, let's have the party, okay? And calcium is one of the things that it releases. Well, why does that matter? Well, calcium carries a 2 charge. It's a cation. Well, those positive charges interact with these negative charges, but also interact with the negative charges on that disrupted endothelial basement membrane that is now exposed. We want that. We don't want clotting factors getting active just wherever they want to in the whole body. That's not a good idea. We want it to be at the site of where the injury has occurred so we don't bleed to death. So these are strategically released and modulated in that environment by those cells physiologically the way they were designed. Unfortunately, they sometimes get overly turned on or activated when we don't want them to be around. Okay? Or we have genetic conditions like hypercoagulable disorders that tip the balance towards unfavorable clotting mechanisms. And so when you create that in milieu or environment that allows that problem to manifest, it shows up. We see this in pregnancy. We see it in patients starting on birth control pills because estrogen increases the gene transcription of clotting factors. So we increase the concentration of them. Well, what if you have a condition like a hypercoagulable condition like factor V Leiden? All those things set up shop that can do that. Well, we want normal mechanisms like this to be intact. But remember, you need reduced vitamin K in order for that chemical reaction to occur, for gamma-glutamyl carboxylase to use it. You see that arrow here. Well, when it does that, it kicks out, when it uses the reduced form, it forms an oxidized vitamin K. Well, then that gets recycled back to reduced form by, guess what? Vitamin K 2,3-epoxide reductase. It's reducing it back. So carboxylase is adding a carboxyl group. Reductase is reducing something from its oxidized state to a reduced state. And that now allows that recycling to occur so that the body can continue to not only make the clotting factors, but functionally activate them when we need to use them. And so that's where then the coagulation cascade starts to come together. So to now make sense of it a little bit more, you have vascular injury. What does that do? Well, remember, it releases, there's tissue factor exposed, there's collagen exposed, von Willebrand's factor that's floating around in the body, deposits in the collagen, it interacts with glycoprotein receptors on platelets, turns them on, activates them, right? Collagen activates the platelet. There's these release of these chemicals, and we're providing the calcium there that serves as cofactors, but also that component that allows the clotting factors to deposit where they're supposed to. So the tissue factor, factor 7A, right, formulation is what turns on and activates factor 10 to go to 10A. But it also turns on the intrinsic pathway, okay, which there's a number of cascades going on here. Okay, I'm trying to give you the big main picture here. But they all converge at 10A. All converge at 10A, okay? Now, once 10A is formed here, you see that we have factor 5A, calcium, that turns on prothrombin to thrombin. And we'll see in a minute that thrombin does a bunch of stuff. Don't take this for granted, but this is one of the reasons why we target drug therapy against it. Heparin targets it, low molecular weight heparins. We have direct thrombin inhibitors for this reason, okay? But they turn on and make thrombin, and that converts fibrinogen to fibrin. Those are those fibrin monomers that, again, is that glue, the duct tape, the stickiness to the platelets and the red blood cells to help us forming that clot, whether it's a white clot, thrombus, or a red thrombus, or predominantly platelets, or predominantly red blood cells and fibrin. It is doing that work. But you also see that thrombin comes over here and activates platelets, amongst other things as well. Okay, so again, I'm not going to spend time talking about platelet physiology and all of its platelet activation and aggregation, but again, I'll refer you to the lecture on that to guide you. Now, we talked about prothrombin, thrombin. When we talk about thrombin, it is the activated form, okay? It is the activated form. And so we need to dive now a little bit deeper so that we can understand thrombus growth but also its stabilization. It's kind of like a scab, right? When you first injure something in their blood, and if there's initial, it'll stop bleeding, but if you just rub it a little bit, it'll start bleeding again very quickly. But if you leave it there for about a day or two, then that scab is hard. That is that stabilization. We don't want clots that are in the wrong place to stabilize. It takes a lot longer to dissolve them, right? And sometimes they can lead to long-term problems as a result of that. So keep in mind the name. Second is the role that thrombin plays in that development. So it propagates itself. It kind of feeds itself. So that's autoactivation. But then it also helps to stabilize that clot. It also protects the clot from being broken down. So it's building something and says, no one touch it. I want this right here. Now, it recognizes that too much of itself, if it's too selfish, can be bad. And you're right, it can be. That's where protein C and S are turned on by thrombin to regulate itself. It's like, okay, I like myself, but I am gonna regulate it myself. Now, this is where we have problems because we have protein C resistance. We have protein C and S deficiency. Well, if it's turning off the coagulation cascade, right, it's regulating it, it's slowing it down, and you remove that or don't allow it to work, well, you're going to facilitate the coagulation cascade. You follow me? All right, so that's why these medical conditions start the pathology make sense. When somebody has that hypercoagulable disorder, they're more likely going to clot. You may not see that, may not know that, the patient may not know that until something new shows up in the environment. Pregnancy, a medicine, surgery. Okay, so let's walk through each of those steps very quickly, one by one, looking at just the coagulation cascade. So autoactivation. So thrombin does an auto feedback on these clotting factors, right? You have factor 11, you have factor 8A. Okay, 8, that's where hemophilia, that's one of the, if you're low in 8, right, that's one of those missing components that increases your risk of bleeding, because if it's not there, you can't propagate this cascade. But what thrombin's doing is activating it, making it more available, right? Same thing with factor 5. We're activating it, okay? Now, what is factor 5? Well, factor 5 here is a cofactor. It's needed to turn prothrombin to thrombin. But you can have what is called factor 5 Leiden, okay, which is basically the target of protein C. That's where protein C would say, no, stop, calm down, factor 5, right? But if you have resistance to protein C and S, because you're like, I don't care what you say, I'm going to keep going, right? That's factor 5 Leiden, protein C resistance. We're going to come back to that. I got a table that summarizes that for you at the end, but I need you to recognize why I'm pointing it out. So thrombin auto-activates, feeds itself, and in the acute bleeding component of something going on, you want that. You want to stabilize that clot and build some plug, okay, like in that image. Now, what about its stabilization? So we've grown it, now we're stabilizing it. So thrombin's going to protect itself, and it does that through a conversion of factor 13, okay? Makes it active, and that protects it from the clot. It also prevents it from being broken down, okay? That's TAFI, all right? So it increases the expression of TAFI and the concentrations, and that protects the clot from plasmin activity. Plasmin would normally be like a fibrinolytic, a thrombolytic. It breaks it down, forms these fibrin degradation products. It's the breakdown products of a clot. On labs, we know that as D-dimer and things like that. Okay? So it's fibrin degradation products. So we always have clot turnover. We're always making clots and breaking them down. And we want that. That's called hemostasis. It's just, again, when it's too much, one direction. So a big clot burden would cause the fibrin degradation products to go way up. That would be suspicious to you that there's some clot somewhere. And that's why we measure things like D-dimers and stuff like that in the lab to try to help us understand what's going on here. Now, what other lab is influenced in here on the coagulation cascade? Well, the extrinsic pathway is predominantly measured by the PT-INR, okay, the prothrombin time, whereas the intrinsic pathway over here is the APTT. Okay? So it's important to recognize that when we're measuring labs, we're looking at things like this and trying to assess which pathway is going on and predominant, and if we have a drug that interferes with one of these clotting factors, okay, then we know kind of a little bit of what's going on. Well, we can measure 10A activity, right? We can measure bleeding times and things like that. We can measure PT-INR. We can do PTTs. That guides us, okay? That guides us. Now, remember I told you that thrombin will regulate itself. So all those things I just talked about in those first three areas is the production, growth, stabilization, and protection of that clot that's formed, right? Remember, it's predominantly fibrin and red blood cells, more of a red clot. Protein C is going to feed back on that factor 5 and 8A and say, stop. I'm holding you back, okay? And so protein C is a target also of warfarin. So when you first administer a medication like warfarin, you decrease the protein C concentrations. Well, you remove the blockade. Well, then what are you going to do? You're going to facilitate clot formation. So that is why protein C and S deficiency is a hypercoagulable environment or state. What does factor 5 Leiden? Remember that factor 5 says, I see you, protein C, but I'm not listening to you. Okay? Protein C resistance. And then lastly, thrombin activates that platelet through PAR. PAR1 receptors, PAR4 receptors on the platelets and turns them on, activates them, that then will facilitate aggregation. And that's why I keep talking about looking at the two systems together at some level versus only learning something in isolation. And so when we come back to our table of the types of thrombus and the characteristics, right, where we have been focusing on are primarily what would be considered venous thrombus or thrombosis events, where it's primarily made up of fibrin, that we saw those fibrin monomers, and then red blood cells, okay, primarily. Not only, there are also going to be platelets in there. It's just not the main thing. So can antiplatelet drugs work on venous thrombotic events? Sure. They're just not as effective, okay? Now, all right, I'm a firm believer that when you learn core content like this, that you need to know what builds on it. You know, and I've been doing that throughout this lecture. This is the foundation for understanding the pathophys and the treatment options that we have to help us modulate the activity. Now, I've been weaving that in on purpose, but I put together for you a couple tables to help you see the big picture of why you're learning this and where it's headed. Now, I'm not expecting you, we're not going to go through each of these as an individual disease state. That's not my goal here. It is a quick overview of the coagulation defects and then some of the drugs that we would use to interrupt the coagulation cascade. And you can see here, I mentioned the word factor 5 Leiden. It's right here. That's activated protein C resistance. And then what you see and what I've done for each of these defects in each row is that we have the arterial thrombus effect, venous thrombus effect, you know, is it predominant, venous or arterial, prevalence, and then some treatment considerations. They're not the absolute end-all be-all, but a generalization of the approach is why I put this together for you. So you can see that all of these, for the most part, encourage venous thrombus formation in varying degrees. So we have prothrombin G2210A level, basically variants. What that is the concentrations that lead to thrombin amounts, right? Antithrombin deficiency, we didn't spend a lot of time on it, but antithrombin deficiency is important. So think about the name, antithrombin. It's antithrombin, which is an important component of the coagulation cascade. When this thing is present, which is endogenously made in our bodies, it is a natural, endogenous anticoagulant, but it's a terrible one. All right? But remember, we don't want extremes. Antithrombin is the target for heparin molecules like unfractionated heparin, low molecular weight heparins, and even fondaparinux, which is a factor Xa inhibitor, right? That's parenterally administered. All of those require the presence of antithrombin in order to work. So if you have somebody who's antithrombin deficient, you are not going to be able to have that pharmacologic desired effect, okay? And it's going to increase the risk of a venous thrombus formation, okay? Protein C and S deficiency. Remember, they're the ones feeding back on that coagulation cascade that is slowing it down, right? Basically acting like an anticoagulant, if you will. But if you're deficient in them, or we give a drug like Warfarin, which decreases the activation of those clotting factors because they're vitamin K dependent clotting factors, then we set the patient up initially in a hypercoagulable state. And we see that with warfarin, bolusing, especially in patients with other hypercoagulable disorders. They are more likely to do that. Hyperhomocystinemia can impact both. Antiphospholipid syndrome is a much more complicated disease, but can affect both depending on where those antibodies are present, and because phospholipids are everywhere. But those patients tend to be best treated on warfarin therapy. Now, what about coagulation defects that increase the risk of bleeding? Those were all things that increase the risk of thrombus formation. But we talked about hemophilia. So hemophilia A is factor 8 deficiency. Hemophilia B is factor 9 deficiency, right? You have von Willebrand's disease. I mentioned that in the lecture where it's floating around, and then when the collagen is exposed because of vascular injury, it unravels itself and it interacts with glycoproteins. It also helps the survivability, the lifespan, if you will, of factor 8, which is one of those cofactors necessary for the coagulation cascade. So you can see that if you're deficient in those, you're more likely to bleed. You don't have the steps to propagate the next step in the coagulation cascade that makes and forms that thrombin that can do those things. Well, we have drugs that can increase or replace those things like cryoprecipitate, which will replenish not only factor 8, but put in some other things in there. You have things like DDAVP that will increase the concentrations of von Willebrand's factor, which is known to also interact and combine with factor 8, increase its duration of availability and action. Those are strategic treatments for those patients, and that makes sense with the coagulation cascade in view. Now, what about drugs that interrupt the coagulation cascade? Depending on where you are in your training, you may not be able to remember these things. That's okay. If you're already a healthcare provider or you're one that's advancing your career and you're learning this or you're solidifying your knowledge, this is where it's going. You need to know how these drugs work because that translates into the desired therapeutic effect that we're looking for. It also explains side effects, monitoring parameters, all those things. So we have warfarin, which is your vitamin K antagonist, remember affecting that recycling. You have your heparin molecule, unfractionated heparin, low molecular weight heparin. Okay, you have your direct 10A inhibitors, a parenteral formulation like fondaparinux, but also the DOACs, direct oral anticoagulants, apixaban, edoxaban, rivaroxaban, that are now used more commonly than warfarin for many conditions, especially like AFib and prevention of cardiometabolic stroke, DVT, PE, those kind of things. And then direct thrombin inhibitors where we have parenterally administered, and we do have an oral subclass of a DOAC as well, known as dabigatran. So that is put together there for you and available at thisiswhy.health for free. We put the link there again in the description, so please take advantage of that. Please feel free to share it, use it, however you see fit, so that because the goal is to share and help each other out, guys. Okay, so now you can see why understanding the normal is relevant to understand the patho and the treatment interventions that we use. This is actually a good time to learn about the platelet aggregation if you have not done so yet. Okay. So I have a lecture on that. It also helps you to understand as you move into some of the disease states and the drug class reviews that I offer, okay? My goal is to help you guys put all the pieces together, build a foundation where you're not memorizing, but you have learned to understand. So I'm Dr. Busti. Thank you again for joining me and allowing me the opportunity to be a part of your education, training, and knowledge. I really appreciate it, and thank you for investing in your own knowledge and career, because your patients are going to be the ones who benefit most from it. If there's any interest in a particular topic, please go to thisiswhy.health and you could submit a topic for future consideration. Thanks so much again for joining. We'll see you next time.